morning to all. My name is Fabio Lugoboni. I am an internist, chief of the Medical Service of Addictive Disorders, Verona University Hospital, Verona, Italy. I wish to explore with you the dark side of the moon, the treatment of benzodiazepine tolerance. Tolerance is something more severe than benzodiazepine dependence. Let me briefly summarize the history of benzodiazepines. The use of benzodiazepines has a history of more than 50 years. The first benzodiazepine, Librium, was approved in 1960 primarily to treat anxiety and insomnia. The 60s saw a rapid diffusion of the use of this drug, followed soon by the still popular diazepam and gradually by several others. As earlier as the 60s, diazepam became the best-selling drug in the UK and the US. Soon after introduction, however, report of benzodiazepine tolerance and dependency emerged. Benzodiazepine tolerance has been reported as early as 1961, but this and other reports during the 60s and the 70s have been obscured by the enthusiastic, easy management in the use of these drugs. Many countries now have recommendations for a short-term use of benzodiazepines, 2 or 4 weeks, no longer. Unfortunately, these recommendations are largely disregarded by patients and doctors themselves. Misuse of benzodiazepine can cause deficit in learning, attention, working memory, depression, and injurious falls, traffic, and other accidents. Overall, the prevalence of long-term use in the general population is approximately 2 up 7%, with estimates for long-term use among benzodiazepine users ranging from 25% to 70%. It has been estimated that tolerance can develop in around 8% of long-term users of benzodiazepine. The problem of use of benzodiazepines is also related to the use of high doses. This is very important. This is the topic of our speech today. Epidemiological research is still lacking in this field. In particular with reference to high-dose users. Based on the few studies taken of the general population, one is to assume that about 2% of benzodiazepine users are not only long-term users, but also high-dose users. In the United States, this would equate to 200,000 people. A common way of thinking has summarily relegated high-dose users to the margins of psychiatric disorders and drug addicts. This is not true. For reasons which are not clear, there is a significant proportion of high-dose users addicted only to benzodiazepine who don't have major psychiatric disorders nor polydrug abuse. A lot has been written about the side effect of organic complication, but research has largely neglected the quality of life of long-term users and almost totally ignored that of high-dose users. In our experience, very, very bad. From a clinical point of view, the only proposed solution of a gradual reduction of benzodiazepine is too simplistic. For long-term users in general, if properly applied, gradually tapering the dosage works, but it is much less effective for high-dose users. This is worth mentioning because withdrawing from high doses of benzodiazepines carries significant risk for the health of the patient. It is in this area that high-dose users that use of flumazenil, this is the point, the topic of today, the use of flumazenil as an intravenous drug has been effective, has proved to be effective. Flumazenil is used worldwide to treat the overdose of benzodiazepine. Experimental findings have shown that flumazenil acts as a benzodiazepine partial agonist with a weak intrinsic activity when administered by slow subcutaneous infusion. Let me repeat, slow subcutaneous infusion. When used in detoxification from benzodiazepine intolerant patients, flumazenil slow infusion showed the following pharmacological properties. First, attenuation of the withdrawal symptoms and signs. Second, very important, normalization and upregulation of benzodiazepine receptors. This is very important. Third, restoration of GABA receptor allosteric structure and inhibition of benzodiazepine-induced uncoupling of the receptor. Tolerance reversion, craving reduction, and, last but not least, relapse rates reduction. We experienced during the last 12 years flumazenil infusion on a large number of patients, almost 700 chronic users from median daily dose of 14 times greater than the maximum dose allowed. Severely benzodiazepine dependent patient, and in our opinion, this treatment can represent a really effective cessation method resulting in withdrawal discomfort of lesser severity than any other cessation treatment available today. Patients usually stop immediately the abused benzodiazepine and rapidly taper low doses of clonazepam in 3 days up to no benzodiazepine on day 4. Flumazenil infusion starts on day 1 and lasts up to discharge at day 7 or 8. Now, we will briefly describe more precisely the characteristics of our patients and how slow infusion of flumazenil commonly applied by our inpatient unit. I told that we select only tolerant patients. I mean subjects addicted from a very high doses of benzodiazepine, not simple long-term users. Well, patients immediately suspend at the admission in hospital the abused benzodiazepine, receiving low doses of clonazepam, tapered rapidly in 3-4 days to complete suspension unless we decide for an agonist substitution with very low doses of clonazepam. The flumazenil slow infusion starts on day 1 and ends at discharge, usually on days 7 or 8. To notice that flumazenil is normally administered as a subcutaneous infusion, not as intravenous one. The daily assessment of withdrawal symptoms usually confirmed a low score of discomfort. Requests to suspend the infusion therapy are generally unusual. So far, only 3 patients out of 700 have ever dropped out the inpatient treatment. Flumazenil slow infusion can successfully applied also in the treatment of alcohol and benzodiazepine co-addiction with illicit drugs as cocaine and so on. As regards the relapse rate, 12 months after the treatment, more than 65% patients were abstinent. 22 were still using benzodiazepine, in example clonazepam, at therapeutic, low dosage, and only 13% were using again another therapeutic dosage of benzodiazepine. So we can say that only 13% was relapsed. Despite these 20 years old findings, I remember that early studies date back to the 90s. There are only 4 or 5 centers globally that offer this method in our knowledge. What's preventing flumazenil being used in this way? I haven't an answer to this question. We hope that these points will stimulate some reflections about the most common off-label prescription usage in the world, that of benzodiazepine. If interested in inpatient treatment by our addiction unit at Verona University Hospital, please contact us by visiting our website